Mute yourself.
Thank you very much for kind introduction. After listening to Dr. Shiva Kumar, I'm just going to show a small presentation which I recorded. If you can look at my screen on 11/11/2020. History of this patient is she is 26-year-old female. She is neither hypertensive nor diabetic. She is non-smoker, non-alcoholic, non-obese, non-hypothyroidism. CAD, there's no history of coronary disease. ECG is normal. NAD was the chest was normal, no snoring. Echogenicity was fair. The only indication for presentation was tachycardia. Let's look at these echo films now with a small history of this. Let's look at the echo films. This is first echo film. If you look at this echo film, you can jolly well say, well, we have a significant amount of mitral regurgitation. We have got some amount of aortic regurgitation. And this LA and LV, both of them are bigger if we measure by 36.2 millimeter per meter square area and LV 39 and 25 with a normal wall thickness. So these were the two things which were dilated LA, dilated LV, and significant of MR as well as AR. This is a static film for mitral valve and aortic valve, and try to concentrate what exactly this static film is telling you in one go. Obviously, LA measurement, LV measurement, and then finally, again a color Doppler. We went on to measure the aortic valve VTI of aortic regurgitations, vena contracta, not VTI, vena contracta. It comes out to 0.43, 0.45, 0.47, classifying into somewhere moderate severity of aortic regurgitation. Short axis, pulmonic flow normal. Then let's look at the LV function now. And very critically, if you look at the LV function, LV looks to be reasonably fine. 4-chamber, 2-chamber, and finally the 3-chamber view. And apart from LV, there's something very important seen in this particular view. 4-chamber, concentrate, that concentration needs a really a good concentration. Significant about mitral regurgitation, we looked at a vena contracta, although overestimated, it comes out to be almost 0.85. I was trying to look at a vena contracta in Plaque's view. Where's the right method? It was coming at 0.6, 0.65, 66, but I was not able to get a perfect. But the most important thing, it is thou overestimated, it comes out to be 0.85. And then we will look at the velocity of mitral flow, that's 2.59. Then A velocity is 2.27. And if you look at the gradient, gradients was 23.54 and 14.58. Important gradients. Then I went on to do a PISA radius for this patient. And as we do a PISA radius for this patient, this comes out to be a little down, 0.21. And the PISA radius after multiple calculation was 0.65. And the MR velocity was 4.56 meters per second. Aortic flow velocity, and we could see signals of AR, we could see signals of aortic flow. Tricuspid, normal, but significant amount of pulmonary artery hypertension in the sense of 3.84, 59 millimeters of mercury. My question at this moment is, we can open up a mic, we can say, are we yes or no? My question at this moment is, the diagnosis, all of us agree, rheumatic heart disease? No difference in diagnosis, because we could see doming, we could say thickening. How about MS? Patient is having a mitral stenosis or not? No. Regurgitation or not? AS or not? AR or not? If I go and dissect one by one, we looked at the mitral stenosis with a gradient of 23.54 and 14.58. Does it belong to severe mitral stenosis? If yes, why? If not, why? And in this circumstances, second is mitral regurgitation. Do we say the mitral regurgitation is significantly present or not? Aortic stenosis, of course, is not there, but we have significant of aortic regurgitation. So we have a mixed lesion of MS, MR, AS or AR. If I exclude AS, then we have an AR. Now, what is the dominant lesion out of this? If I've got a patient like this, Should I continue with the medical management or should I go for surgery? So I have to decide what is a dominant lesion for this. And for showing a dominant lesion, I'll have to go further a couple of slides and then I'll come back to subsequent effects. Now, does AR affect the assessment of mitral valve severity in MS, MR, AS-AR? Let's look at this. MS with aortic regurgitations, 60% of those with rheumatic mitral stenosis will also have AR. In approximately 10% of them, AR would be severe. We were moderately severe. In remaining, it will be mild. Now, but the question is, the presence of AR will shorten the pressure half time and in turn overestimate the mitral valve area by pressure half times. So if I go back to my slide, what was my pressure half time? My pressure half time was is seen in the subsequent slides. The pressure half time was, I'll come back to that again. And second thing is, the eccentric jet, if it hits on an AML, which is doing in our case, a reverse can happen. PHT will be falsely increased, resulting to underestimation of mitral valve area. So both the things of AR reflects in mitral stenosis. And what do we do when we have this AR with mitral lesions? This pressure half time could be overestimating, could be underestimating. Then we have to rely on planimetry. And when we went on to look at a planimetry for this patient, the planimetry area was, here is a planimetry area, 2.81. Now the gradients were very high. They were suggestive of mitral stenosis, but planimetry in presence of AR or otherwise will give a fairly good idea. We don't only do a planimetry by 2 dimensions echocardiography, we do a planimetry by 3 dimensions echocardiography also. Here is a cursor line which just cuts on the tip of mitral valve leaflet. The area is 2.92. By 2 dimensions, we were getting 2.8. By 3 dimensions, we are getting 2.92. So one thing is out, mitral stenosis. Let's get down to next, mitral regurgitation. If you happen to look at this mitral regurgitations, especially in this especially in 3 dimensions view, look carefully what exactly is happening in this 3 dimensions view. There's a flail AML which is seen over here. And once I showed you a 2 dimensions windows for functions, not only this, there's a absolutely sometimes there's non-coaptation of the mitral valve leaflets. So we are moving towards severity of mitral regurgitations. And if I have to look at the severity of mitral regurgitation, the best method which is available as on today is a PISA method, and which I did in this patient. This was where the calculation was 2.3 pi r square into velocity of aliasing into PISA radius. What comes out to be almost 0.3 is a effective regurgitation orifice area, which is severe is 0.3. So in turn to say that this patient which has been having a moderate aortic regurgitations, there is no significant LV hypertrophy, LV-LA they are dilated with evidence of flail AML that is seen specifically. Now look at this view, which is a frozen view. There is absolutely non-cooperation of mitral valves. And with this kind of a lesion, and which is categorically seen with 3 dimensions echo, where we can see a flail leaflet in transthoracic echo itself, with the mitral valve area is 2.92, it could be under or overestimated by pressure half time, but we have to rely on 3 dimensions or 2 dimensions mitral valve area, which is normal, and MR is contributing to all the gradients, and we have to think of this patient. Now we can also look at an LA appendage for this patient via oblique imaging. Same thing, 3 dimensions transthoracic mitral valve area. IVC normal, and this is the final report for this patient. If you happen to look at the final reports, dilated LA, dilated LV, normal wall thickness, ejection fraction is almost, when we calculate it, it came out to be almost 55%, which is low. When LV-LA is dilated, it has to be overactive. It has to be hyperdynamic. The LV function started falling down automatically. And we talk of then normal RV-RA, gradients are almost 64 millimeters of mercury. The most important crucial point is dilated LA, dilated LV, what we've seen over here, then thickened mitral leaflet, restricted cusp motion, flail AML, non-coaptation of mitral leaflet with increased flow velocity and gradient suggestive of progressive mitral stenosis. Mitral veil area 2.07 by planimetry, pressure half time, which is over or under, and we were supposed to underestimate because the jet was falling down in AML. Then planimetry 2.81 in 2 dimensions, 3D 2.92, severe mitral ligation both by vena contracta as well as by PISA method, patient in normal sinus system and tachycardia. Thickened calcified aortic leaflet with restriction of cusp motion with high normal flow velocity with moderate AR with ARVC of 0.43. This is what the sum of this patient is. This patient was referred to us for evaluation whether this lady needs a valve or a medical management. Second issue now. Let's come down to practical. She's 26. She's unmarried. Another problem. And on top of that, she is, by culture and by religion, she's a Muslim lady. So what do we do with this patient now? If you look at all the parameters, whatever we talked about, she is a one candidate who should go to metallic valve. But she has to be at the child's. So what do we do? That's a big question. If I have to give a question and the patient is ready, we have to give her a bioprosthetic valve. And bioprosthetic, we have to take care of her religion also. So that's what all I wanted to talk about this particular patient, which was referred to us only 3 days back for their final opinion. Thank you very much for your patience here. I'm open for questions.